Hey fam, it's Dr. Yola. I know it's been a minute since I've been out here in these social media streets sharing information, but I think I'm in due course to jump back into it and share some information. For those of you who do not know me, back during the pandemic, I spent a good number of hours either on YouTube, Facebook, or Instagram helping us collectively navigate through the pandemic, trying to provide trusted, evidence based information. And towards the end of the pandemic, I felt like we were moving through it sufficiently for me to take a rest. I decided to spend some time resting, recovering, falling in love. I got married since last I was on social media, spending a lot of time as little mommy's mommy, given the fact that my baby girl's getting ready to head off to high school. But I wanted to jump back into it really because of the executive order that came out yesterday. I'm sure for a good number of you, it was a little bit surprising, a little disconcerting to hear an executive order coming out related to public health interventions in clinical work. But here we are. And so I figured if my families who have called me, my patients, and some of my friends who have reached out benefit from the information that I have shared with them, that I should share it with my collective family as well. For those of you who do not know me, my name is Dr. Yolanda Hancock. That's my good government name. Out in social media streets, I am known as Dr. Yola. I am a pediatrician. I have practiced for over 20 years now. Even more importantly than that, I am a mom. And I guess a third component of who I am is that I have expertise in public health with a master's in public health from the Johns Hopkins University. And so I think it's important whenever anyone is sharing information that we understand with whom and from whom we're getting this information. All right. So I hope that this is helpful to you, especially for families navigating decisions around immunizations. I will put out two caveats. The first is one, I don't debate the safety and efficacy of immunizations. If you are anti vax, if you have strong opinions about immunizations and not wanting your child to get them, make that your choice. But what I don't do is debate or argue both in person and in social media. So if you have a comment and it is not productive, it does not speak to facts and instead is either disinformation, misinformation, or just downright rude or nasty, it will get deleted. But if you do honestly have a question, my families know that I welcome all questions and I welcome all families. At my practice, at my pediatric practice, I do not deny care for any family regardless of immunization status. So your baby can be fully unimmunized or fully immunized. You're welcome in the fold of Dr. Yola's practice. I think it's important to create safe space for families to make the decision that's right for them. Although I do not professionally or personally have any concerns around the safety or efficacy of immunizations, I definitely can understand why families want to approach it cautiously, which is one of the many reasons why I don't deny families based on immunization status and um, understand why some practices make a different choice, but that's my personal choice in terms of welcoming all families. The second part of that is just to extend grace and understanding to families right now, especially those who are navigating making these immunization decisions. It's a hard time because you don't know who to trust. You don't know how to make sometimes a very clear, confident decision based on different things that you may read, hear, and or see. What I would invite you to do is not just listen to me because if you don't know me, you're just meeting me, but also connect with your provider, your pediatric nurse practitioner, physician assistant, or pediatrician and ask them questions. And obviously, if you feel judged, if you don't feel like it's a safe space for you to be able to ask those questions, then find the practice that does align with the ability to be able to ask those questions. All right. I welcome all questions, even for families who may have read something online. They may see a TikTok video or an Instagram. I will ask them to share it with me just so that we can talk it through and give an honest answer. If there's a question that I don't know, I will tell my families that I do not know, but then we will work together to find out the answer. When it comes to immunizations, I will tell you that For the most part, I know a lot, not just because I have been a pediatrician for over 2 decades, but because I'm a mom and I wanted to make sure that I knew when it was time for my daughter to get her immunizations, um, what we were doing, both in terms of combining immunizations, the timing of the immunizations, all of those things. And so that's sort of where we are in terms of sort of the tone of this conversation. And I really hope that although I'm talking to you, I hope that you feel that I'm talking with you. So let's talk through what these executive orders included. The first was reducing the standard vaccine schedule from about 18 diseases being protected against down to around 11, using the term gold standard to create a model that is a gold standard for immunizations in a similar vein to what Denmark is doing. And we'll talk about why it's inappropriate, one, to compare Denmark to the United States, but also why that's not a gold standard. And what does that even mean, gold standard? The second is looking at moving certain immunizations to what we call a risk based approach. If your child is at higher risk for disease A, B, or C, then they are the ones who should get the immunization and not others. The other component of the executive order was separating out the measles, mumps, and rubella vaccine to take it from 2 shots to 6 shots. So let's jump into it. The first thing I want to do is just really talk through what the immunization schedule is. I hear a lot of conversations in social media streets about the number of stabs or jabs that children get. And I'm not going to use that language because I feel like it's a way to politicize immunizations. So we're either going to call them shots, or we're going to call them vaccines, or we're going to call them immunizations. But we're not going to call them stabs or jabs because that gives a violent connotation to it. And I know I'm not stabbing or jabbing anybody. So let's talk through what shots children get. We'll talk with under five first. So for a little one under the age of 5, they get 5 DTaps: diphtheria, tetanus, and pertussis. We usually do it at 2 months, 4 months, 6 months, and somewhere between 12 and 15 months, depending on when that first shot was given. The next immunization that children under 4 get is the polio immunization. That is also given at 2 months, 4 months, 6 months, and along with DTaP, we give that one at the age of 4 as a last polio, and the DTaP is given as a last DTaP at the age of 4. The next immunization is Hib, also known as Haemophilus influenza. That is also given at 2 months, 4 months, 6 months, and again between 12 and 15 months. Prevnar, also known as the pneumococcal vaccine, it's given at 2 months, 4 months, 6 months, and guess what? And again between 12 and 15 months. The next immunization, hepatitis B, most times is given at birth, 2 months, and then the last dose is given at 6 months. Hepatitis A is given at 12 months and then again at 18 months. The rotavirus vaccine is given at 2 months, 4 months, and 6 months. The measles, mumps, and rubella together is given at 12 months and then again at 4 years. And the varicella vaccine, also known as the chickenpox vaccine, is also given at 12 months and given at 4 years of age. So 5 DTaps, 4 polios, 4 Hibs, 4 Prevnars, 4 Hep Bs, 2 Hep A or 3 Hep Bs, 2 Hep As, 3 rotavirus vaccines, which are given by mouth, by the way, 2 MMRs, and 2 varicellas. That's 29 injections, 29 vaccinations by the age of 4. Not 50 something, not 60 something like what I'm hearing in social media. And you may add on an additional one if your baby qualifies for the RSV shot. Now, the RSV shot isn't specifically a vaccination; it's actually a monoclonal antibody. But for these purposes, we will classify it as an immunization, even though it works a little bit differently in terms of the components. So even if a baby gets the RSV shot, that's still only 30 by the time they get ready to go to school. And then when they turn 11, they get a Tdap, tetanus, diphtheria, and pertussis, the grown-up version of the DTaP. They will get one meningococcal immunization and they will get a 2-part HPV, human papillomavirus vaccination series. So that's 29 or 30. And then you add on an additional 4. So that's 34. And then when a child turns 16, we usually do a secondary meningococcal immunization to further protect them from meningitis so that when they head off to the military, college, etc., they're fully protected. So that's an additional one. So we're talking about 35 immunizations, not 50 something or 60 something as claimed by this current administration. I'm not quite sure where they get that number. It may be that they're including annual flu shots and quarterly COVID-19 vaccines. I don't know, but those are the immunizations as is scheduled by the American Academy of Pediatrics currently, and what was previously, prior to this administration, part of the routine childhood immunization series. That's it. And it's not the size of either a 12-ounce Coke, a 24-ounce Coke, or a liter. This is it. This is the size of the vial that immunizations are usually stored in, or it's a longer, thinner tube. This is what's called a pentacil, and this is a combination of DTaP, Hib, and polio so that children don't have to get 3 different needles at once. This is the volume, zero point 0.5 cc's, half a cc. This is the volume per immunization. So even if you combine, if you gave a child all of their 2-month shots individually, you're certainly not going to get to the volume of a Coke, not even a shot glass of a Coke. So the exaggeration really made no sense, and it is downright dangerous, especially if you've not had a baby but plan on having a baby and you don't know what immunizations look like, or you are preparing to take your child in for immunizations. But any adult who's received a shot or any parent whose child has received a shot knows that we're not pulling out Coke bottles for shots. It's just this. All right. So that's the first thing, is understanding what the vaccine schedule looks like so that we can then talk about, should we compare ourselves to Denmark? What I will tell you is that one, Denmark is not gold standard. The majority of developed high income countries have significantly more immunizations than Denmark. Denmark has the lowest number of immunizations required in the pediatric population, not because it's the best choice, it just means it's currently the right choice for Denmark. We have to compare apples to apples, and comparing Denmark to the United States is like comparing broccoli to apple slices. Completely different food groups, different textures, different flavors. Makes no sense to compare them. It makes no sense to compare broccoli to apples, and it makes no sense to compare Denmark to the United States. Denmark, 6 million population. United States, 330 million. So population by itself means that disease presence is going to be different. How Denmark deals with the measles outbreak is going to be a whole lot different than what happens here in the United States. One, simply based on sheer numbers. So Denmark has a population of 6 million people. The United States has around 330 million people, right? We know that policy choice, what policies work in a specific place, whether it be a city, a state, or a country, nothing is the same. The policies that work in Maryland aren't necessarily going to work in Virginia, aren't going to necessarily work in California. Same thing across countries. It does not make sense to use a policy in country X and apply it to country Y as a general rule of thumb, but especially when there's such significant differences. Not only is Denmark significantly smaller than the United States, it's much more homogenous than the United States. The beauty, one of the beauties of this country is it is a wonderful mixing pot of different groups. You don't see that as much in Denmark, which also means that the way that we're dealing with different infectious diseases is also going to be different. There's a lot more mobility within the United States. People are moving a little bit more, comparatively speaking. It just does not make sense. Okay. When we look at Denmark, the diseases, the childhood diseases that they're dealing with, some of these are very, very common across the board, but the level of protection is different. One, because Denmark has a universal healthcare system, meaning that everyone is covered. They don't have to worry about 45 different insurance companies. They don't have to worry about coverage of care. None of those things are issues in Denmark because everyone has insurance. So if a child in Denmark does get measles, they have faster, clearly affordable access to care when that may not necessarily be the case here in the United States. So, how things will be transmitted will be different in terms of disease spread from child to child. Because here in the States, you may be dealing with a child who does not have health care insurance, they may have minimal coverage. All of those factors influence what happens with these different diseases when it's passed within the pediatric community. So until the United States gets universal health care, or at least all children are covered universally, and we have paid sick leave, we can't appropriately compare Denmark to the United States. When we look at the different immunizations, the series, etc., with our data, we're looking at data here in the United States, but we're also looking at data across the globe, as is the case with Denmark. But here in the United States, there are different baseline numbers of the different diseases that we're dealing with. If you look at other countries, they're not having the same measles outbreak that the United States is, and it is because our measles immunization rates have declined so significantly. We have to compare the United States to the United States, right? The other issue that I wanted to address is this idea about excluding various immunizations to make them what we call risk based as opposed to universally administered. So, is it that all children get fill in the blank vaccine, or is it based on a child specific risk related to the infection that that vaccine protects against? And we'll take them one by one. And I'll tell you later on in another video, I'll talk about each of these vaccine preventable diseases, what the vaccines do to either prevent the disease or decrease the risk of severe infection, what happens when you get the disease, how do we treat it, is there a treatment, etc. But I just want to give a general overview in explaining why these particular immunizations should not be switched to risk based because almost all children are at risk for the disease and the complications resulting from the diseases that these vaccines protect against. So let's jump into it. RSV, respiratory syncytial virus. It is an upper and lower respiratory infectious bug, a virus. It is the leading cause of hospitalizations for U.S. infants here in the United States. It's the most common cause of viral pneumonia and bronchiolitis among little ones under the age of 2, and it is one of the leading infectious causes of later development of asthma. So when a child has an RSV infection, they are at increased risk of developing asthma. All children, not specific children, all children. Around 80,000 children per year are hospitalized due to RSV, and between 100 and 300 children die under the age of 5 every single year because of RSV. And these are children who have not been immunized against RSV. Although there are certain risk factors, prematurity, underlying lung disease, sickle cell anemia, those kinds of diseases, all children, particularly under the age of 2, are at higher risk for severe RSV disease. It's the reason why the immunization was initially created. And again, I mentioned this at the beginning of our talk together. RSV specifically is a monoclonal antibody. It's not a vaccine in our traditional sense, but it triggers the immune system in the same way. And I don't know if you guys remember when we came out of the pandemic, like around 2022, all of a sudden there was all this buzz about RSV as if it was a new disease. It was because our children had not been exposed during quarantine. They ended up being exposed, so we started to see these surges of RSV between 2022 and 2023, and we continue to see those same surges now, particularly among children who are not immunized against RSV. Based on the current data we have, thanks to the monoclonal antibodies that we have available for our little ones, it cuts respiratory disease in terms of having severe symptoms by almost 90% and decreases the rates of hospitalization by 98%. So a baby who gets RSV, who's immunized against RSV, has a 2% likelihood of going to the hospital. For babies who are unimmunized, their risk of being hospitalized is significantly high. And this is all children. All children are at risk for significant RSV infections. There are certain risks that I mentioned, but all children are at risk for severe infection and the possibility of getting hospitalized. No one can guess which child is going to be the child that has a severe infection. I will tell you from my own patients, perfectly healthy little ones under the age of 2 who have ended up in the hospital with no underlying health conditions. There would have been no way for me or the mom or dad to have known that this was going to be the child that ended up hospitalized. You just never know, which is why a lot of these universal recommendations are made because children are collectively at risk for more significant infection. All right, so that's RSV. The second one is the rotavirus vaccine. So, rotavirus is a virus that causes gastroenteritis on the streets known as the stomach flu. It's before we had the rotavirus vaccine, between 55 and 75,000 children were hospitalized every single year due to the rotavirus infection, and between 50 to 60 children were dying every year because of the rotavirus infection. Again, we don't know which children are going to be those 55 to 75,000 children or those 30 to 60 children per year. I knew I didn't want it to be my daughter, which is why I chose for her to be immunized against the rotavirus infection. Because of this immunization, we have seen hospitalizations decline by about 80% since the start of giving the rotavirus vaccine. And I will tell you, um, the system works when it comes to vaccine surveillance. So, your girl is not an early adopter of immunizations. When they first come out, I like to have a good sample size, about 10% of a population getting it before I give it to my families, looking at the side effects that have been reported, looking at the adverse outcomes, which are the really bad things that may happen with certain medications, vaccinations, etc., so that I can make an informed decision about using that intervention and I can transparently talk with my families through making that decision. Rotavirus was one of them. So when the rotavirus first came out, or the rotavirus vaccine first came out over 20 years ago, when I first started practicing. I was like, I'm gonna wait a little bit, see what happens. What was shown was that babies who had the rotavirus vaccine, their intestines had what's called intussusception, where your intestines telescope inside of each other. It's almost like the intestines turn inside out, which can become a surgical emergency. Guess how they found out this was happening? Clinicians were reporting it, hospitals were reporting it, and parents were reporting it. And because this information was being reported back, the drug company took the product off the market. Rotavirus was taken off the market. We stopped giving it because the system works. They re envisioned the formula, they did more studies, they put it back out on the market. You know, your girl waited a little bit, a couple of years to be exact. We weren't seeing that same relationship because, again, we've been able to report it out for the past at least good 15 years, we have not seen those same issues with the rotavirus vaccine. So for those who say, oh, doctors are just drinking the Kool-Aid, they're just out here pushing these shots out, getting money from Big Pharma, well, no, we're not. Pediatricians are the lowest paid of all specialties within medicine, and it certainly does not, we aren't incentivized to do things to hurt children. Our first One of our first components of the Hippocratic Oath is to do no harm, and we take that no more seriously than in pediatrics. I know across the board in all specialties we take that very seriously, but particularly in pediatrics our whole focus for the most part is on preventative care, and the rotavirus vaccine being taken off the market, redeveloped, put back on the market, and not seeing those same relationships shows that the system of reporting, correction, redevelopment, reintroduction, and using it safely works. What we do know is that children who are getting this vaccine are protected. Those who are not, who do not have the rotavirus vaccine, are 4 times more likely to be hospitalized. That's what the data shows because, again, we are reporting this information out to trusted sources. This isn't opinion, this is data driven information. And looking at a period between 2008, when the immunization was reintroduced once they fixed it, to 2013, almost 400,000 hospitalizations and $1.2 billion were saved because babies received this immunization. Again, there is no clear, discerning component outside of perhaps prematurity to determine which baby, which child is going to have a severe rotavirus infection. But I can guarantee you, every parent whose baby was in the hospital with the rotavirus infection, who ended up being in the hospital, I think they might have wanted to get their child vaccinated so that they wouldn't have to go through the experience of their children being dehydrated and hospitalized. I know, again, for my daughter, when it was time for her to get the rotavirus vaccine, we said absolutely yes, because I've taken care of babies in the hospital who had rotavirus, who ended up in the ICU because of rotavirus, and I did not want to take that chance with my daughter. All right, so we talked RSV, we talked rotavirus, let's talk hepatitis A. So hepatitis A is also one of those that they're trying to do it from a risk-based standpoint, which for me really makes no sense because there is not necessarily a risk factor associated with hepatitis A. All of us can get it, to be honest with you. Anyone who's not immunized can go on to develop the hepatitis A infection. Hepatitis A is transmitted through either contaminated food or dirty fingers, right? And so when little ones are either eating at restaurants, and I'm telling you, I have some of my babies, their parents will give them a little nibble as early as 6 months when they're eating at a restaurant. It could be at daycare, it can be in the school setting. For each of these, I have a scenario. So before Dr. Yola became a doctor, she taught elementary school. When I taught elementary school, we had a hepatitis A outbreak because the frozen strawberry slushy cups were contaminated with hepatitis A. For those of us, like myself, who were immunized, we were protected. Those who were not went on to develop nausea, vomiting, jaundice, significant belly pain. And this wasn't just a day, this was like weeks of discomfort. We don't want to put children through that. And there is no clear cut, well, patient X is at higher risk than patient Y. All patients are at risk. All pediatric patients are at risk of hepatitis A infection. So there's no risk stratification when it comes to any of these, but particularly when it comes to hepatitis A. And I know you're going to ask me, well, doc, why at 12 months are we giving this immunization? Like, babies aren't, do they really eat out? Yes, they do. I would ask your friends and family, if you don't have kids, how often do you take your babies and give them a little nibble of whatever it is you're eating? Even processed foods. We're in the middle of at least three different outbreaks of some sort of cootie, cyclosporiasis, salmonella, etc. It is in our food systems. And just like those bad frozen slushies, strawberry slushies that we got when I taught elementary school, it could happen on any daycare campus, preschool campus, or school campus. That's why we prevent, so that we do not have to deal with little ones, or not even deal with putting children at risk for these infections. All right. We know that hepatitis A is the most common cause of pediatric infectious hepatitis. It's part of the reason why we immunize against it universally. The other is hepatitis B. And I know you're going to say, ooh, doc, why are we doing this at birth? Like, this makes no sense, especially if as a mom, I know that I'm hepatitis B negative. I got the vaccine. My husband got the vaccine. One, why do we need to do it at birth? And two, why do we need to do it at all? Why can't we do it when the child is older? And give you a science-based, evidence-based reason why that is the case. I'll talk to you about what it was like before because I've practiced long enough. So I practiced before this was the universal rule. When I was training at the Cedar Sinai Medical Center in Los Angeles, what I would have to do as an intern and then as a resident was hunt down prenatal labs. A mom would have a baby. We wouldn't know whether or not the mom had hepatitis B. There would be no prenatal labs available. And what I will tell you, there's a window of time that we have to figure this out. Either we're calling the OB, trying to get mom's labs faxed over. We're calling the laboratory to try to get the lab ordered for mom so that we get the results in enough time to help protect the baby, right? Or we're doing a combination of those things. It took a lot of time. It took a lot of work. It was very frustrating because while I'm taking care of babies in the busiest NICU or nursery in the state of California, and probably one of the busiest nurseries in the country, taking care of babies, trying to stay on top of making sure I get however many of these prenatal labs I need or following up with the laboratory, I will tell you, I'm sure even for myself, there were a couple of babies that likely slipped through the cracks, either because mom had no prenatal care, we couldn't get the facts, we couldn't get the lab result in enough time, we didn't know what to do. And instead of creating stress, frustration for all of us, part of the reason why we decided to universally approach it with giving babies hepatitis B, part of it was that. The second part was that of around 18,000 babies and children who tested positive for hepatitis B, only 50% of them got it from their moms. According to this administration, you only get it from sex, which is not true at all. You can get hepatitis B from other methods, right? So babies can pass through the birth canal and be exposed to hepatitis B. They can get it also from close contacts. So 50% of babies and children got it from their mommies, but 50% of babies and children got it from somewhere else. And we didn't necessarily know where that somewhere else was. It could have been the other parent. It could have been a grandparent, an auntie, an uncle, a cousin. It could have been at school. In my practice, I use Ray Ray as an example. So no diss to anybody's baby boy named Ray Ray. But what I explain to families is your baby boy or girl is in daycare. Ray Ray has hepatitis B. He bites your son or daughter, breaks the skin, causes bleeding. His saliva gets in that cut. And although the risk is very small, there's still a risk. So instead of us playing Russian roulette with the possibility of babies getting hepatitis B, and not just acute hepatitis B, I have to make sure we understand that if a child is exposed to hepatitis B either at birth or at any point in time during their lifetime, especially as children, they are at higher risk of having what we call chronic hepatitis B. So 90% of babies born to mommies who are hepatitis B positive, who have hepatitis B, they will also have hepatitis B. 9 out of 10 babies born to mommies who have hepatitis B will go on to have it themselves. There is no cure for hepatitis B. Over time, hepatitis B causes inflammation of the liver, and eventually that liver will get inflamed. There's a possibility that that liver will fail, and that child may need a liver transplant, or that child as an adult may die due to liver failure. Again, in pediatrics, we're all about prevention. So if I can prevent a baby from developing future chronic hepatitis B, that's what I'm going to do. That's why we do that at birth. So that between birth through school age, this child has been protected at every stage in which they may interact with someone who may have hepatitis B. And because we don't know, like I don't know what my cousins, my uncles, my aunties' status is. I think I know my mother's status. I'm pretty sure I know it. I was born without hepatitis B, so I can assume that she was hepatitis B negative. And then I got my hepatitis B immunization right before I went to college because that was when it was indicated at that time. But with more data, we make more informed, better decisions. We look at what happens to children over a period of time and we say, how can we protect these children? How can we prevent things like chronic hepatitis B? And that's where a birth hepatitis B plays a role. And then we continue to protect them through infancy so that we decrease that risk of chronic hepatitis B. All right, so let's talk about meningitis because that's another one that's on the chopping block in terms of moving it, not removing it completely, but making a risk stratified immunization. So the Neisseria meningitidis causes meningitis, an infection within the brain, but other parts of the neurological system, right? Um, the scary thing about meningitis is that it goes quickly. Symptoms can develop so fast, medical intervention usually does not start in sufficient time. And even when there is appropriate medical intervention that happens in a timely fashion, about 15% of children and young adults who have meningitis are still going to die. And of all those folks who get meningitis, 20% of them will go on to have very severe health outcomes. They may lose limbs, they may lose hearing, they may lose kidney function, they may develop other neurological disorders like seizure disorders, intellectual disabilities, attention deficit, hyperactivity disorder, problems concentrating. All of these things can happen as a result of having meningitis. And I I say I have personal stories for all of these. One is because I've practiced for as long as I have, but I also have family members who have dealt with this. I lost a cousin to meningitis, and although she was too young to have received the immunization, what I can only think about is who was around her that passed meningitis to her that could have been immunized and protected. Because we don't just immunize to protect the child, we immunize to also protect the people that that child is near, right? And so, yeah, I lost a cousin to meningitis. I know how significantly impactful meningitis can be, and I would not put that on anyone to have lost a child due to meningitis. So in 2005, the meningitis vaccine became available. And again, I'm going to give you this example because it shows the system works. So when it came out in 2005, again, your girl was not going to do the new one. She waited. And I'm glad that I did when it first came out because the newest, the oldest, I should say, meningitis vaccine was associated with something called Guillain-Barré disease, a temporary inflammatory disorder of the nervous system. Folks recovered from it, but there was a higher risk of it with the meningitis shot compared to the general population. For that reason, because we collectively, as physicians, clinicians, etc., reported it out, again, it was taken off the market, re envisioned, redeveloped, retested, put back on the market, and for the past 15 years or so, we have had no issues. What it has done is protected children against meningitis, decreased the risk of spread by about 75%. It's done the job we envisioned it to do. It's important because if your child is getting ready to go to the military, go to college, any environment where he or she is going to be around a lot of other children in their age group, meningitis spreads like wildfire, and you want to make sure that they're protected. And again, there's no way to assess risk. You don't know which child is going to be in that 20% that's going to lose a limb, lose hearing, lose cognitive function, etc. That's why we universally immunize children to protect them all. All right. And we do this both at 11 and at 16 in order to boost it. And the reason why we did a second meningococcal vaccine at the age of 16 was that, again, data driven. In 2010, the data showed that the immune response started to dip down after about 5 years after getting that first immunization. And one of the things I want to make sure I talk about is sort of why we do these multiple immunizations, because that's the other question I often get. Why do we need two meningococcal shots? Why do we need five DTaps? This is what happens. In a study population, similar to what we saw in COVID, this was science in live action during the pandemic. So I'll use the COVID-19 vaccine as an example. So the COVID-19 vaccine was given. All of the different pharmaceutical companies monitored immune response. And when they saw the immune response start to dip down to the point where it no longer was protective, they were like, oh, we need a boost. So they give another shot. It brings the immune response back up. They continue to follow to see where it dips down again. Unfortunately, with the COVID-19 vaccine, it dips down every 4 to 6 months, which is why we have that whole booster approach to it. But for a lot of immunizations, and I'll use polio as an example. So we give the vaccine at 2 months. Immunity starts to dip down after about 2 months, so we give it again at 4 months. We follow, we follow, we follow. Immune response starts to dip down a little bit at 4 months. We boost it back up. Immune response good and dips down at not until 4 years. They continue to monitor. So from 6 months of age to 4 years of age, immune response is nice and steady. At around four, it dips down a little bit. We boost again. And subsequently, after four, we haven't had to, as of yet, needed to boost for polio, but we also eradicated polio. We haven't had a case of polio in decades here in the United States. It shows that the vaccine has worked. We're not having outbreaks of polio. The IPV, which is the abbreviation for the polio vaccine, it's maintaining a steady state of immune protection, right? The same thing with measles, mumps, and rubella. It dips around that 4 year age mark, so we give another boost. And it has remained steady thus far, even though we are dealing with another outbreak of measles. We have more cases of measles now than we did before we had the MMR immunization. We came close to eradicating it. We had eliminated it, meaning no routine cases in the early 2000s. And then because of the anti vax movement, we started to see a decline in immunity from decreased immunizations. So who knows? We may have to get another boost. Like I might have to get boosted for measles again in my 60s. I hope not, but it's a possibility based on what our immune systems are doing as it relates to the environment in which we live. So that's what's going on with meningitis and why we have to do that boost at 16 and why we have to do sort of these incremental boost shots for almost all of the immunizations. But for most of them, we reach a sweet spot where the immune response is nice and steady over years. The other immunization that has been moved to sort of a risk assessed immunization is the flu shot. Again, we don't know who's going to be at highest risk in the general population. We know that there are specific populations that are at highest risk. The youngest of us and the oldest of us, those who are premature, children who have underlying lung conditions, they are at the highest of risk, but we know that the youngest of us are at highest risk. And so when children get a flu shot, one, it decreases their risk of severe illness, especially for the youngest, that 6 month to about 2 years. But for older children, it also protects their 4 month old sister, their 85-year-old grandmother. So it isn't just for themselves, but it's also protecting the people around them. Just in the 2024 2025 flu season, we lost the highest number of children to flu in comparison to since we've been counting deaths from influenza in the pediatric population. We lost almost 290 children in the 2024-2025 flu season, higher than any year since we started counting child deaths related to flu. It's only getting worse. The numbers continue to climb. We don't know which child is going to be the child that succumbs to the flu, which is why we universally immunize children as per family request. Flu is not part of the required immunization series. We certainly offer it at 6 months and older. But to say that it should only be given to children at high risk, all children are at risk for significant flu infections. So we definitely need to take that into consideration. We know that because of flu immunizations, we saw decreased hospitalizations by about 75% for individuals who were vaccinated against the flu. They were significantly less likely to be hospitalized. And then the last one is COVID. We know that there have been challenges with COVID-19 immunization uptake in the pediatric population. Did COVID-19 impact children's health? Absolutely. Did more children die from COVID back during the pandemic than they did from flu? Yes, they did. Thankfully, as COVID has continued to mutate and change, we're seeing less severity when it's come to COVID across the board. And so I still make COVID-19 immunizations available to my families per their request. Again, the COVID-19 vaccine has not ever been on the CDC schedule as a required immunization, although it may have been required by your employer. For some schools during the pandemic, it may have been required. It's definitely something we encourage but do not require. All right. So that's that. Let's talk about separating this MMR. The MMR immunization was introduced in the early 1970s. I received an MMR. Most of us received the combined MMR. The concerns around the combination immunization, I will tell you, are just unfounded. It makes no sense. It sort of does make sense because there is a former doctor, mind you, I said former doctor who presented research back in the late 90s attempting to do two things. One, there was an attempt to associate MMR vaccine with autism, which has never been shown to have true scientific relationship. The other relationship that this former physician attempted to do was to show that there was some bad outcome from combining measles, mumps, and rubella in a singular vaccine. The data was significantly flawed. The data was tweaked to prove the hypothesis, and the study was based on 12 children. 12 children. Anyone, you don't even have to be in public health or ever having done the study. You cannot extrapolate large scale information based on a study population of 12. It's just not appropriate. But that's what this former physician did. Because it was discovered that he lied about his data, misinterpreted data purposely to prove his hypothesis, he actually lost his medical license. The study was initially published, but then The Lancet, one of the most world renowned medical journals in the world, initially published his findings, but once they determined that his findings were inappropriate, they retracted the study. But as my grandmother would say, the horse was already out of the barn and the anti vax movement was birthed. But the data that shows the protection of the MMR vaccine remains the same. We know that MMR combined does not cause any health effects. As of 2019, a Danish study looked at over 650,000 children to determine whether or not there was a relationship between autism and the MMR vaccine. There was no relationship shown. There have been many subsequent and previous studies to show that there is no relationship between the MMR vaccine and autism. They even went so far, we went so far as to take the thimerosal, the preservative, out of the MMR immunization. It did not show any difference because thimerosal is not the reason why we're seeing more autism diagnoses. It's because we're better at it. There are other factors at play that we can talk about later, but it is not the MMR immunization. And we know what happens when you separate them. Japan showed us that. In the early 90s, Japan decided to take the MMR and separate it out. What they were able to show is that when they separated it out, vaccine rates declined significantly. So about 70% of people who got the combined shot came in for their second part. For people who separated it out by three parts, it was only 50% who received all of those doses. And in our health system, the likelihood of families being able to go from a two-shot series to a six-shot series seems very improbable. It means more shots for the child. It means more visits for the parents. It means trying to find a space on your pediatrician's schedule to get them in to get the shot. You're hoping that while we're spacing these shots out, which has not been scientifically proven to be effective, and it does not yet exist, that your child's not going to be exposed to measles, mumps, or rubella in those intervals of time. In order for this to even happen, they have to develop out the measles, the mumps, and the rubella shot because those separated immunizations were taken off the market back in the early 2000s. They're going to have to develop it, research it, test it, put it out on the market, get it approved, and then possibly have insurance companies cover it. In addition to the additional visits that families will have to schedule, and it's going to be highly unlikely that any of those things are going to be feasible for families. My daughter got the MMR at her 12-month and 4-year visit. I don't remember it, but I know I got the MMR because I still have my yellow card. And here I am still able to walk talk about it. I have no concerns around them. I do have concerns about misinformation and disinformation. And I hope that the information that I'm presenting, talking through with you guys, is helpful. I hope that it answers questions that you may have. It helps to address any fears, concerns that you may have. Feel free to drop a question, a comment, as long as it is not disinformation, misinformation, or disses, because I will not engage. But if you honestly have a question, I welcome them all. My families, whoever may be listening, will attest to the fact that I welcome questions. If I do not know the answer, I will let you know that I don't, and we will work together to find an answer. But I do hope that this information is helpful to my families out there. I love you guys. Thank you for trusting me enough to partner with me, particularly when it comes to decisions around immunizing your children, whether you do it or not. I love you in all the ways and am here for you to address any concerns that you have. We'll continue these conversations. I won't wait for executive orders to come out. We will definitely continue these conversations relating to not just immunizations, but general child health. I feel like I'm ready to jump back in. My apologies for my absence over the past, I guess it's been a couple of years now, but your girl is back. Please let me know if you have any questions. Love you guys. Take care of each other. Please take care of your babies. Dr. Yola out.